Let's talk about narcolepsy in adults. So narcolepsy, it's a lifelong neurologic disorder. The onset, it can be early, like age 4 or 5, but usually it's in the teens and 20s. And it's a disorder in which REM sleep intrudes into wakefulness. There are two types. Type 1 has narcolepsy with cataplexy, and type 2 is narcolepsy without cataplexy. The disease is multifactorial. There is one gene that has been identified, the HLA-DQB10602 mutation, that is present in almost all type 1 narcoleptics. However, this gene is also present in most of the normal population as well. So the main clinical feature of narcolepsy is chronic daytime sleepiness, and this is present universally in all patients. This can also manifest as sleep attacks, where when someone's going throughout their day, they'll all of a sudden get sleepy and have to nap. One thing to note is that the total amount of sleep in one day, though, is normal. Cataplexy happens in about 60% of patients, and this is where you'll have transient muscle weakness without loss of consciousness. This can be triggered by strong emotions such as laughter or excitement or grief or anger or sadness, and it typically begins in the face. You can have just the head drooping, or you can completely fall to the ground, but importantly, there is no loss of consciousness. You can also have hypnagogic hallucinations when falling asleep. This is more common than hypnopompic hallucinations, which is what happens when you're waking up from sleep. You can also have sleep paralysis for a minute or two when falling asleep or waking up. You can have frequent nighttime awakenings, and obesity is a common comorbidity. The most common psychiatric comorbidities are depression and anxiety. So how do you diagnose this? It's with a sleep study. So before you start a sleep study, you have to stop all stimulants and antidepressants. Depending on the half-life of the medication, you'll have to stop the medication for 1 to 4 weeks prior to the study. So you start the night with a polysomnogram, and this is to exclude alternate causes of daytime sleepiness, with obstructive sleep apnea being the most common. Some features that you can see, though, in narcolepsy: you can have quick onset of REM sleep, such as within 15 minutes of sleep. You can also have increased spontaneous awakenings throughout the night. The multiple sleep latency test is the next test that is done in the next morning normally, and here is when you give people multiple opportunities to take a nap, and you see how long it takes for them to fall asleep. So laboratory tests can be done if the sleep study cannot be done, such as, for example, if someone is not able to stop their antidepressants, then sometimes these ancillary tests can be helpful. So CSF orexin is low or absent in cataplectic patients. And almost all cataplectic patients also have the HLA-DQB10602 mutation. However, note that this is not specific. So, what's required for the diagnosis of narcolepsy? You'll need to have 3 months of symptoms of daily irresistible need to sleep or lapses into sleep. On the multiple sleep latency test, you'll need to see 2 or more sleep onset REM periods, as well as a mean sleep latency of less than 8 minutes. And then for type 1 narcolepsy, you'll need to also see the symptoms of cataplexy or a low CSF orexin. And in type 2 narcolepsy, there's no cataplexy and typically a normal CSF orexin. Type 2 narcolepsy can be difficult to detect on the multiple sleep latency test because there can be false positives and false negatives, so the test may need to be repeated. So for treatment, first you'll want to treat any concomitant sleep disorders such as obstructive sleep apnea, basically other sleep disorders that can also cause daytime sleepiness. Maintaining a regular sleep schedule is important. Sometimes people will need planned daytime naps. Exercising will help maintain wakefulness as well as help combat obesity. Psychiatric comorbidities should be treated, such as depression or anxiety, and patients should avoid substances or drugs that can worsen the symptoms, such as alcohol, benzos, opiates, or antipsychotics. There is medication treatment as well. Modafinil and armodafinil are typically used as first line in maintaining wakefulness, but methylphenidate and amphetamines can also be used. There are 2 medications that were put on the market in the last year. Solriamfetol, which is an oral selective dopamine and norepinephrine reuptake inhibitor that is also FDA approved to treat the daytime sleepiness, and pitolisant is a oral H3 receptor inverse agonist, which is also approved. For treating cataplexy, you can start with the REM sleep suppressing medications, such as venlafaxine, fluoxetine, and atomoxetine. Pitolisant can be helpful if both the cataplexy and the daytime sleepiness are both especially bothersome. And sodium oxybate can be used as well. So in terms of the prognosis, this is a lifelong disease. It might get better in the last decade or 2, but it typically does not affect life expectancy.